Hello, I want to tell you how the new Ouch tab in the National NIPE screening system is going to revolutionize the way that we treat dislocated hips in children. So this is talking about the Ouch tab along with two studies which are going to be embedded within that, which are called SMARTY and SMARTER. And it's all about improving screening and improving the treatment of DDH in children. We all know we've got the screening program and we all know that Barlow and Ortolani is useful, but we know we've got problems with the screening program. Screening has got a but, and it's a big but. 6 out of 10 cases are missed by the current examination. And we published that a few weeks ago in JAMA. So every 1,000 babies examined, we identify 4 dislocated hips, but 5 are missed. And in response, NHS England and NHR have got together and pioneered this new Ouch tab to really improve the way that we screen and treat dislocated hips in babies. We know everywhere there's controversies about how to screen, when to screen. It's done slightly differently in Scotland versus England. And then even when we diagnose DDH, there's lots of uncertainties about when we treat, how to treat, when we stop treatment. So always we've had a system called Smart for NIPE for the last few years at least. And this routinely collects details from midwives about the risk factor the child has for DDH. And then if the child has an ultrasound, it collects details whether the ultrasound's normal or abnormal. One of the challenges is that people often mean something different when they use the words normal or abnormal. So this is what's done at the moment. So the midwife assesses the risk factors, and then the ultrasound documents whether it's normal or abnormal. In our new modified pathway, we're going to let the midwives do what they do best. So record details of the clinical examination and the initial findings. And then the ultrasound, instead of just saying normal or abnormal, it's going to include the Biscoe's core measurement set. And this is already live across the UK. So is it hip centered on ultrasound? What's the alpha angle? And is it dislocatable? And then if we make a diagnosis of DDH, it's going to collect really basic treatment details. And that's going to allow us to do randomization here. So we can randomize between different treatments. So different types of splint, different times of using the splint, different types of weaning regime, loads of different things we can do as part of routine care. And we can also randomize here. So we can randomize screening. So we can randomize between new artificial intelligence screening versus conventional screening versus whatever else you might want to randomize to improve the screening program. So this is what's currently live across the UK in all hospitals. So when a baby has an ultrasound scan, instead of saying, is it normal or abnormal, which is a bit meaningless, we say, is it centered? What's the alpha angle? And is it unstable on dynamic ultrasound? And that can be not done because I know that's not done everywhere. So super, super simple. Here it is, even bigger, just to emphasize it. And then the other thing, which you have to tell us about, to tell us to go live on, but we want this to be live across the UK, and it's very much fulfilling GIRF agenda and everything else, is what's called the Ouch tab. So all about overcoming variation. So the Ouch tab is here. So the idea is that whenever you see a baby in your DDH clinic, you give us some really proper details. So it's going to ask about the ultrasound details. So if you've already put this in the other tab, this will be automatically populated. So it's going to ask you, so in this case, the hip wasn't centered, it was a bit dysplastic, and the dynamic ultrasound wasn't done. So was the clinical examination performed? So then it wants you to tell us about how the hip was in clinical examination, and it asks if X-rays were performed. And it only asks that, I think, if the baby's above 4 months old, is what the lockout is. It asks you what the follow-up is. So you're going to see the baby again. Well, in this case, the baby's got a very dysplastic hip. So they're going to be followed up in a week's time. And treatment today has been started with a Pavlik harness, and it's been worn for 23 hours a day. So super simple, super basic details. And then the next time the baby comes back to clinic, the idea is that you enter the baby again. So you'll put the new date that they come. The first question, so it knows they're in a harness. So the first question is, have they got any complications of their harness? So you'll tell us whatever complications it's got. Again, super, super simple. So have they had an ultrasound today? And the answer probably is going to be yes. So again, in this case, the right hip's nice and normal. The left hip, I'm hesitating here. The left hip is centered and it's less dysplastic, but it's still dysplastic. Was the clinical examination performed? So it's normal on the right side, and on the left side, they've got a dislocated or they've got a normal hip, so it's stabilized. Was an X-ray performed? We'll say no. And what was the follow-up? So we're going to have follow-up ultrasound, and that's going to be done in how many weeks? In 2 weeks. And so is the baby in treatment today? So this is currently a bit ambiguous, so it's going to change. Is the baby in treatment today? And so they're going to be in a Pavlik harness, and they're going to be in the harness again for 23 hours a day. So super, super simple. And so then each time they come, you'll just enter the details again. So have they got complications? No. Was ultrasound performed? Yes. And so this right hip, I'm guessing, is still nice and normal. This left hip, I'm hoping, is going to have normalized. Let's see. There we go. So it's nice and normal. And no X-ray was performed. And so the plan in this case, so it's all got nice and normal. So we're not going to do any further ultrasounds, or are we? Okay, so in this case, we're at the point now we're not going to do any further imaging, and we're going to discharge them with a normal hip. And I know this is all a bit artificial stuff. So imagine you've got a baby that comes in at a year-old who's never been treated for DDH. So kind of forget about this. So imagine this is a new baby in the system. So they've come at a year-old, and so we haven't done an ultrasound. We in this case, for some reason, we haven't done a clinical examination. Not sure why, but anyway, the X-ray shows they've got a dislocated hip. So we're going to say that they've got a normal right hip, and on the left side, they've got a dislocated hip. The acetabular index is 50 degrees, and we've said what surgery we're going to do. So super, super simple. And so the reason that bit's important is because that's going to allow us to identify all of the hips which go through the screening program identified as normal, and then subsequently have a dislocated hip. So they're just as important to enter those patients, or perhaps even more important to enter those patients, because we need to know who the screening program is missing, and that's what we don't know at the moment. So why is this important? Well, this is important for the Getting It Right First Time agenda. So we know that GIRFT, so the GIRFT report, said that we need to make accurate returns on the smartphone IP system. And if we're in control of it, it means that our returns are going to be nice and accurate, and they're going to be meaningful. We need to ensure that we need to try and minimize the duplication of returns, and by using this as our primary system, that's going to minimize any duplication. It also said that we need to or BISCOS needs to complete further trials and pilots of universal ultrasound screening. And this is very much what this is geared to. If we all do this together, we could randomize 50,000 babies every single month in England. And we're trying to join in the devolved nations, particularly Scotland and Wales at the moment. So SMART-E is about where we're bringing the whole system together. We're able to do a big observational study, and I've got a team that's helping me do that. So SMART-E is smartphone IP, integrating evidence, and then SMARTer is where we randomize. So SMART, embedding randomization. It's going to be cool. It's going to be amazing. Do reach out to me. I want everyone to join in, because it's only going to work if we all do it together and if we make this our routine care. Thanks so much, guys.